Good afternoon, my distinguished colleagues and the respected members of the Asian Pacific Organization of Physical Medicine and Rehabilitation. I would like to express my heartfelt gratitude for the opportunity to address this esteemed international conference and meet physiatrists from all over the world, even if only through the virtual realm. My name is Tony Ho-Chi Su, and I'm a senior attending physician affiliated with Chang'an Memorial Hospital in Taiwan and Xiamen. Today, we gather not in person, but through the marvels of technology that bridge distances and connect us together across borders. I think this topic that united us today is very important in the world of sports medicine, which is sports-related musculoskeletal injuries in pediatric and adolescent athletes. The landscape of sports medicine is evolving rapidly, and nowhere is this transformation more evident than in the realm of young athletes. The vigor and enthusiasm of our youth athletes are inspiring. Yet, the unique challenges they face in terms of musculoskeletal injuries demand our attention. In the next 30 minutes, we will share our experiences about the epidemiological trends, risk factors, and innovative approaches to managing and preventing these injuries in our young athletes. These discussions transcend borders and cultures, as the well-being of our future athletes is a shared responsibility. Therefore, I encourage each of you to actively engage in this virtual dialogue, pose questions, and contribute your insight if possible. Together, we can advance our understanding and elevate the care we provide to our young athletes. Thank you for joining this virtual session, and let's unite in our commitment to the health and the performance of our young athletes across the Asian Pacific region and beyond. All of the topics discussed in this lecture has no financial interest. My present voluntary committee work, including Center of the Comprehensive Sports Medicine in Chang'an Memorial Hospital, Jiayi, Taiwan, and the Child Developmental Assessment at the Intervention Center. I also serve as the Xiamen Chang'an Memorial Hospital and serving as consultant physician in Beijing Qinghua Chang'an Memorial Hospital. I also serve as board of Sports Medical Association in Taiwan and the Taiwan Taekwondo Sports Association and the Taiwan Association of Early Intervention and Physical Medicine and Rehabilitation. I have been attending LCPRM for over 10 years. This is the picture we took last time in 2010. Then I served as the moderator in the section of myofascial pain. These are the books and the publications I have written recently, including pain and physical medicine and manual therapy and pain control and muscle pain and injury preventions in sports athletes. And some of them are about geriatric patient and obese prevention and acute and chronic pain and myofascial pain. All of my slides in the following lecture will be cited from my books, unless other mentioned. For the past 2 decades, I have consistently visited school at various levels on a monthly basis to engage with young athletes, addressing sports-related injuries and offering training guidance. I feel blessed to accompany and participate in the growth of these young athletes. As a team physician, my foremost duty is to safeguard the well-being of these young athletes throughout their training and competitive endeavors, thereby facilitating their peak performance in every match. Therefore, the importance of tailored treatment and training recommendation cannot be overstated. Different sports disciplines require distinct treatment and recommendations. For example, the treatment options are different in pitcher, batter, and catchers. The location and the severity of sports injury are also vary in different sports. Even within the same sports category, there are still differences in sports injuries between male and female athletes. Similar differences exist between Asian, Caucasian, and Arabic athletes. I have once provided treatment for sports injuries to athletes from the Jordanian youth and national teams. These differences varies a lot according to the physical status, the training status, and the reaction in competition. In recent decades, we have noticed a significant increase in children and teenagers participating in sports in Taiwan, often starting at younger ages and engaging in more intense training early on. This trend has contributed to a rise in injuries among young athletes. Surprisingly, we are now witnessing various of injuries in young athletes that were once mainly seen in mature athletes, which we call it paradigm shift. The majority of injuries of young athletes result from repetitive strain due to overuse, instead of sudden traumatic events. Various nationwide surveys provided data on sports injuries. They use different methods to define these injuries. The most common approach to consider the amount of time athletes spend in participating in the sports. Additionally, factors related to the growth and development of adolescent athletes can influence the types of injuries they experience. We will first provide an overview of the epidemiology of the musculoskeletal injuries in children and adolescents involved in sports in Taiwan, as well as compared to the other countries like United States. In definition, children and adolescents are defined as individuals from 6 to 19 years old, or we call them youth. They are more physically active than their adult counterparts. According to the ACSM, American College of Sports Medicine, 42 of the 6 to 11-year-old meeting the physical activity guidelines. However, in 12 to 15 years old, only 7.5% and 5% in the 16 to 19-year-old has meeting the physical activity guidelines. To the SESM's guideline, they call for children and adolescents to engage at least 60 minutes per day of moderate to vigorous intensity of physical activity, which is approximately 3 to 6 metabolic of equivalent of task. And in these physical activities, they can include vigorous intensity of physical activity. which means over 6 metabolic equivalent of task, 6 MET, resistant exercise and bone loading activity at a level at least 3 days per week. In addition to these physical activity guidelines, the expert panel also recommended that children should limit the total entertainment screen time to less than 2 hours per day. These are also very important to athletes in Taiwan, so I highlight them in red. Basically, children and adolescents are physically adapted to endurance exercise training, resistance training, and bone loading exercise. Therefore, if these exercise trainings can improve cardiometabolic risk factors, weight control, bone strength, and psychosocial well-being, they might be help to prevent sports-related injuries. Most young individuals are healthy and they can do moderate intensity exercise training without medical screening and vigorous exercise after safe participating in moderate exercise. Because the pre-puberty children have immature skeletons, therefore younger children should not participate in exercise of excessive amount or vigorous intensity. According to ACSM, basically the physiologic responses to acute graded exercise are quantitatively similar to those in adults. However, there are some important differences. Some of them are related to the efforts of body mass, muscle mass, and height. Children have a much lower anaerobic capacity than adults. Therefore, they will limit their ability to perform sustained vigorous intensity exercise. As we can see in this table, youth athletes compared to adult athletes, they have lower absolute oxygen task, lower cardiac output, stroke volume, systolic and diastolic blood pressure, and the tidal volume and the minute ventilation. However, they have higher relative oxygen uptake, higher heart rate, and higher respiratory rate. Children and adolescents should be encouraged to participate in physical activities that is enjoyable and age appropriate, and they should include unstructured active play, which consists of sporadic bursts of moderate to vigorous intensity of physical activity, with brief periods of rest. Of course, it is better to count toward FITT recommendation, which I will express in the next slide. Exercise is medicine. This is the exercise prescription for children and adolescents, which is recommended by ACSM. As we can see, there are major 4 items in this exercise prescription, which are frequency, intensity, time, and the type of exercise. There are 2 more items in the latest version of recommendation, which are the V and P. V means volume, and the P means progression. The exercise recommendation should look like this way, which means there are aerobic resistance training and bone strengthening exercise. For example, we can see for the aerobic training, they should done daily, including vigorous intensity at least 3 days per week. As for the intensity, they recommended moderate intensity, which means that approximately 3 to 6 MET. And for the time is suggested to over 6 minutes per day. And the type of exercise, the importance of enjoyable and developmentally appropriate activity, like running games, hiking games, hopping games, jumping rope, swimming, dancing, bicycling, and sports like soccer, baseball, or tennis. Adolescents may participate in strength training activities if they have received proper instruction and supervision. Generally, adult guidelines for resistance training may be applied in youth athletes. However, because of the immature thermoregulatory systems, they should avoid exercise in hot, humid environment and should be properly hydrated and modify activities whenever possible. We also recommended that we should decrease the sedentary activities like television watching, surfing the internet, and playing video games, and increase activities that promote lifelong activities and fitness like walking and cycling. The research of the sports injury in youth, the epidemiology is often difficult to compare because the definition of different papers are varies. Here we collect general accepted guidelines, which is the time lost from practice or game, decreased level of activity, and the need for medical attention. However, these definitions have limitations, include the reliability of the collected data and the bias of the self-reported recall, and there is not enough qualified professional to record the injuries. Here, we also use the definition from the CDC for sports injuries, which is these injuries are resulting from participation in organized high school athlete practice or in competition. And these data require medical attention from a certified athlete trainer or a physician. And these injuries may restrict the athlete's participation for 1 more days beyond the date of the injury. These are the factors of specific significance in adolescent athletes' sports injuries, which are height and weight, muscle growth and strength, motor skill and performance, and body composition, flexibility, gross cartilage, bone structure, and psychological maturity. For example, the increase of height and weight may increase to the momentum and the force during collision with other athletes. Increased weight will also increase stress and load to skeletal structures. As for the motor skill and performance, motor skill generally improved during adolescence. It is associated with improved motor performance and contribute to the improved sports-specific task performance. Males and females will follow a different path. As for the body composition, we should always check the body composition at the monthly level because some of them will engage in unhealthy measurement manipulated by body fat mass, which is, as we know, is the female triathlete syndrome, or now we can also see in male athletes, which are we call the REDS, the relative energy deficiency syndrome. And in adolescent athletes, there is attention should be paid in growth of cartilage because the immature growth plate is very vulnerable to stress injury. These are the overuse musculoskeletal injuries in young athletes. As we can see, the structure affecting articular cartilage and subchondral bone, like juvenile osteochondritis dissecans, which we call that OCD. OCD should always be noticed if the patient have a persist, long, uncurable medial or lateral epicondylitis. As for the apophysis, osgood-Schlechter disease, which is the bulging and the painful tibial tubercle, which is often seen in athletes in volleyball or taekwondo. As for the bone, There are some high-risk stress fracture areas like femoral neck, patella, or tarsus, or navicular, or fifth metatarsal, which are often seen in long-running athletes, marathon athletes, or track and field athletes. As for the bursa, there are many bursitis in the youth athletes more than the adults because the bursa in child and adolescent are often thicker than adults. Therefore, the bursa in shoulder, elbow, wrist, or even knee will easily get injured during repetitive exercises. As for the growth plate injuries, more attention should be paid in teenager athletes like wrist or humerus. The distal radial physis or proximal humeral physis is not unusual in these teenager athletes. As for tendons, there are always tendinitis like a rotator cuff, like in the wrist decurvent tendinitis, and for the runners, the popliteus tendinitis or ITB band, iliotibial band friction syndrome, are very common in runners. As for the medial and lateral epicondylitis, is also seen in tennis or table tennis. As for the osteitis pubis affecting symphysis pubis, like the runners, they will have the inguinal pain or a pre-pubic pain. We should always think about this. As for the factors contributing to overuse skeletal musculoskeletal injuries, like a sudden increase in the intensity, duration, and volume of physical activity, poor conditioning, or insufficient sports-specific training, or poor training techniques, or inappropriate equipment, they are common, more consistently associated factors. Less consistently associated factors, including anatomic variations like flat foot or hallux valgus. Hard playing surfaces is also noticed, and the stress to the gross cartilage or differential growth between bones and muscular tendinous structures, or decreased flexibility, or neuromuscular associated conditions. Sports-related musculoskeletal injuries by location, like shoulder, elbow, wrist, pelvis, knee, ankle and foot, and spine, we can see the most common in older youth from contact sports like wrestling, football, or hockey, or soccer is shoulder. Whenever the shoulder is painful with ecchymosis, a clavicle fracture should always be considered. As for the elbow fracture, like a supracondylar or lateral condylar fracture, is not uncommon in athletes of tennis or table tennis. Throwing athletes, osteochondritis should always be seen if the elbow pain is persistent. Like stress injury, flexor tendinopathy, or collateral ligament injury is often seen in overuse injuries. As for the wrist fracture is also commonly seen in athletes of premature epiphyseal fusion. As for the lower limb like pelvis and hips, knee, ankle, and foot, this painful area should always be checked if there is a epiphysis or epiphyseal injury first in these youth athletes. As for the knee, osgood-Schlechter disease is commonly seen because the skeletal immaturity. As for the ankle and the foot, we should always see if there is ligamentous injury or if there is a painful swelling ankle. As for the tarsal coalition, which is commonly seen as a variant of flat foot, which is presented with limited range of motion in ankle dorsiflexion and plantar flexion. If the plantar flexion associated with painful sensation, then posterior ankle impingement should be concerned. As for the spine, they are mostly from the high-risk sports like football, diving, skiing, or gymnastics. Intervertebral disc herniation is commonly seen, or Sherman disease, spondylolisthesis, or spondylosis, which is often presenting as back pain, like in gymnastics, dance, or cheerleading, or football, or weightlifting. These spinal injuries are generally common in older adolescent athletes. These are data from the United States. These are the common injuries for boys among popular high school sports. Most of them are contact sports, and these are recorded from injuries per 10,000 competition plays. As we can see in football, hockey, wrestling, lacrosse, soccer, and baseball, the most common area is head and neck and shoulder. Head and neck shoulder is commonly seen in contact sports. The next one is ankle. The third one is knee. The fourth one is hand and thigh, and this is the trend and the calculation, the distribution of the injuries. For the proportions of injury in practice and competition, we can see there are a little different trend in practice and in competition. In practice, we can see the sprain and strain has over 50%, and in the competition is less than the 50%, and the contusion is more in competition, more than in practice. As for the fracture, the percentage is about the same in practice and in competition. As for the contusion, in competition is more than the practice. The above slides are the data from the United States. Actually, we have done our own studies to record the high school sports-related injury surveillance study since 2013. These are the data from the pandemic from 2019 to 2021, and this is the multi-center study. We have studied 10 senior high school and 6 junior high schools. Among them, we have documented 6,000 of injuries in training and 476 injuries in competition. During the 2-year studies, we have divided the injury size of practice to the younger and the older. Younger group is 7 to 9, and the older group is 10 to 12. Here are some results from our surveillance study. And as you can see, in the injuries of youth athletes from 7 to 9th grade, injuries size on practice from the 7 to 9th grade. The first is the knee, the second is ankle, the third is wrist. In the older group, you can see the knee, the ankle, the lower back, the clavicle, the wrist are the 5 most commonly involved areas of injuries, which means that in the same category of sports, different areas of injury will be noticed in different age groups. And in the older group of athletes, there is more commonly lower back and clavicle injuries. For the same group of athletes in competition, we have noticed that a slightly different in distribution on injury sites. The knee, the ankle, the lower back, the clavicle are still high in competition. However, we have noticed that the thigh injury, the calf injury, the pelvis injury are increased on competition, which means that the lower part of body injuries are more commonly seen in competition. Therefore, the early diagnosis and the treatment in the lower part of the body is essential. These are the number of injuries of different sports in practice and in competition. The left side one is the in practice. We can notice that the number one is the volleyball. The number two is badminton. However, in competition, we can notice that there are a lot more injuries in badminton, which shows that badminton might be a severe sports in competition, which will cause more injuries than the other sports. Slide also showed the number of injuries in practice and in competition in different sports. As you can see, the badminton is number one in practice and in competition in number of sports injuries. The second one is taekwondo. The taekwondo has more injuries in the practice than in competition. And the last one is the track and field. Track and field, we can see the injuries in competition is more than in practice. From the previous data, we have observed that as the athlete getting old, the number of lower limb injuries increases. Therefore, early diagnosis of lower limb pain is important for young athletes. As here are some common pain areas young athletes may encounter, like the lower back, the hip, and the thigh regions. And we should pay attention to the insertion and origins of these muscles in the pelvis and hip regions. For example, if the pain happens here in the iliac crest, we should notice that if there's some problem in sartorius muscle or in the area is the tensor fascia lata. For the inguinal area, we should notice that the adductors and hamstring, because this is the insertional point of these two muscles. It is also the same in the greater tubercle and the lesser tubercle. The greater tubercle is the gluteus medius and minimus, and lesser tubercle is the iliopsoas muscle. In this article, we present a new method in treating myofascial pain in upper back. We use dry needling under ultrasound guide to observe the immediate effect, like the physical parameter and the size changes of myofascial pain before and after the dry needling, which is published in Taiwan Journal of Physical Medicine and Rehabilitation in 2003. Sometimes painful sports injury might be associated with traumatic neuropathy. At this moment, high-resolution ultrasound plays an important role in early diagnosis of the traumatic neuropathy. This is the case we present in 2009. We also use the real-time calculation to build the 3D model of myofascial pain, which is also a very powerful tool in assessing the morphology of myofascial pain. As we previously mentioned, some anatomic variation which may affect sports performance or even causing sports injuries. This is an example, accessory navicular bone, which will affect the performance of foot and causing some sports injuries like tendinitis of tibialis posterior. In this case, we use high-resolution ultrasonography for the early diagnosis of accessory navicular bone. And you can see the clear pictures of accessory navicular bone, which we called increased diathesis over here. And this article we have published in 2011 in American Journal of Physical Medicine of Rehabilitation. The innovation in diagnosis is the early reveal of dysfunctional kinetic chain or lower limb or low back problems of unknown etiology like accessory navicular ball. I have compiled these research contents and put them into the chapter of image diagnosis of muscle pain syndrome in the Chinese textbook on muscle pain. We have also successfully built an animal model for detecting myofascial pain under the instruction of my teacher, Professor Hongzhang Ren. Then we can diagnose myofascial pain in the early stage of sports injury. We can see here, this is the MUAP of trigger point. This is the non-trigger point. Sports injury-related myofascial pain, dry needling in the remote area will also effective in treating myofascial pain. Here we present a model in treating myofascial pain using remote acupuncture or remote dry needling. In this case, the patient will suffer from the myofascial pain in the upper trapezius, and we use the dry needling in the leg, which decrease the pain threshold and increase range of motion in the remote area. Joint sprain is commonly seen in sports injuries. The key to recovery is the healthy status of synovial site or chondrocyte. We find the folic acid deficiency will trigger apoptosis of synovial site. Therefore, we have concluded that the folic acid supplement is crucial to our joint health. The folate supplement might play an important role in joint health. In different molecular weights of proteoglycan, from the hyaluronic acid, chondroitin sulfate, keratin sulfate, heparin sulfate, we find that the chondroitin sulfate will improve and enhance the proliferation and migration of human chondrocyte, which is the key to recovery of many sports injuries. Therefore, we have concluded that chondroitin sulfate supplement is also promising in joint health. Conclusion, this is the take-home messages. Most youth athletes can tolerate moderate intensity exercise without previously medical screening. And in our study, knee, ankle, lower back, and wrist injuries are most common site of youth athletes. And the sports injury patterns in youth athletes are different on practice and on competition. Ultrasonography is very useful in detecting early musculoskeletal and nerve injuries in youth athletes. Myofascial pain in youth sports injuries need careful examination, which we can use ultrasonography and EMG for early detection. Folic acid and chondroitin sulfate are important supplement and promising for joint health. Thank you. I hope we can meet in Taiwan in the near future.